There is no more opportunity to enjoy the evening of a Saturday than the traffic jams which happen in all the big cities around India, the Saturday evening. People all go out for shopping only that Saturday evening. And when it comes to clinical practice, there is also a traffic jam. We feel that we are comfortable with one line of thinking. We also learn new things. And beyond this, we might see a new or an unpredictable scenario. These questions which were shared by the participants, you can understand that these type of questions keep coming to us. After attending any number of courses, still these questions will come. Differentiating between two pathologies, which one to treat first, how to decide which is more severe. So there are a lot of things which is better treatment. Why not that treatment compared to this treatment? There may be a question about evidence, the research, or there may be a question about the underlying effects, whether physiological and therapeutic effects. AOMPT has been experimenting way beyond human expectations. And we are coming up with a course of ultrasound therapy. You may be wondering, like, all the people are teaching all advanced osteopathy and chiropractic courses, and AOMPT is coming up with ultrasound therapy, because Ritu ma'am had told long back itself, we need to improve the electrotherapy, because electrotherapy is an inherent part of physiotherapy, without which patients don't come to us daily, without which the effect or the recovery will not be a holistic one. Okay, maybe some patients expect the treatments with machines in addition to the hands, in addition to the adjuncts like tapes or cups or IACM tools. When that multimodal treatment is given, every patient has the greatest likelihood of improvement. But at the same time, we can't just combine everything and then give for everybody. We need to see for that problem what rationally we can apply. As a clinician, what is our concern is what the patient is worried about. The patient is worried about only one thing. Every patient commonly asks only one question to the clinician. What is that one question? Can you put it on the chat? Ritu ma'am, you feel my audio is not clear?
Yes, sir. It's very low voices coming, I think.
Did you increase the volume and see your device
Yes,
volume?
my phone is having the full volume I have set, but it's that they're pressing the voice.
Hold on. Now how is my volume?
Better, sir.
Better, okay. Right? So,
yes, sir.
What is that one question which the patient asks every clinician? What is the common question? Most common question or the most challenging question which a patient asks to a clinician? Absolutely right, Dr. Chaitanya. 10 out of 10. The patient always asks the question to the therapist that how many days will I take to become normal? How many sessions? This is the question which every patient is concerned. Especially, they ask this towards the end of the first session. They don't ask in the beginning of the session. They are happy to give the history. They are happy to cooperate for your examinations. They might clarify with the treatment options what you have, and they might give the consent, and they are happy to cooperate. But after the middle of the session, suddenly they will ask this question. You will feel like first session is going on, it's not yet ended. Still the patient is getting anxious, okay? Not having much confidence in me as a therapist. So they are asking this question. But the truth lies in the fact that I have a problem in stair climbing. hip, knee, or ankle. The first session of treatment, if you make the patient to be in supine, and we give an electrical modality, we give a thermal modality, we give exercises in supine, and then we apply manual techniques also in the supine or prone or side lying on the plinth. Definitely you are likely that you will get this question 100 out of 100. Because the fact is very clear, patient is not able to relate the technique of treatment to the functional recovery. How a treatment in supine lying will make me to climb the stairs? Stair climbing is my problem. So how long, how many sessions will it take for me to climb the stairs? That concern comes. The alternative, if you see that you have put the patient in the steps, in the stair climbing on the day one, they have pain on stair climbing. You have modified that position of the legs. You have modified the load on the leg using the therabands. You have modified the load on the joints by giving mobilization forces using the mobilization belt. So either kinetically you modify with the therabands, kinematically you modify with the mobilization with the movements, the mulligans, which is indicated for functional issues. And the first day treatment involves patient in stair climbing position, and then you are initiating the treatments. Although electrical modalities, many of them cannot be given in the stair climbing position, you might use it maybe in supine or prone only, but at least exercises and the manual therapy, many advancements have come where those techniques can be applied in the stair climbing position. Definitely the patient will avoid to ask how many days I will become normal, because they know that their problem is stair climbing, and the first day we are actually attempting to solve that problem. So maximum in 1 week, they should be normal. If we treat them out of the goal of the patient wants to run, patient wants to play a competitive game, but you treat the patient in the supine, sitting, standing, in the department only. You have never taken them to the field, the sports athlete. Definitely the athlete will have a concern that I have the game coming up in 3 months. So how can I be fit to play the big level game? Because we have never taken them into the field. We have never challenged them as they are routinely habituated to. A common outpatient treatment is nothing for an athlete, because the athlete requires the highest loading, whether it is muscles activity or it is joints, sustaining the forces, the number of repetitions, the conditioning, every level is higher for an athlete. You can't treat an athlete together similar with the normal outpatients. And the same way, children with developmental anomalies, the parents will ask how many days the child will take to walk, especially if you are treating the child in the supine lying. Usually neurodevelopmental therapy. What do? We make the child to be supine, we train the rolling, we train the quadruped positions, we want the baby to crawl, we want the baby to kneel, then only standing, then only walking, the developmental progression. But the parents will get restless. When will the child be walking? Already the child is 5 years, not walking at all. So what can I do to increase its walking? Can I provide a ankle support? Can we give a walker? So the parents are aggressive. It's expected. That is why in our treatments, it's important on day one to concentrate on what the patient or the caregiver wants. If we do not concentrate on that, it's very difficult to answer that question of how many days you will become normal or you will be back into functional activity. So start the functional activity on day one.
That is the principle of all the certification courses and the programs what we have in AOMPT, the treatment techniques. So although we are discussing as a clinical decision making, you should know that if I say mobilization techniques are effective, I mean the mobilization techniques that are taught by the AOMPT. It's not the mobilization technique which is taught all around. If a myofascial release will be helpful, or if I am telling that there is another called as fasciomuscular release, it means that it is an approach of the AOMPT. Unless you are entering into that and learning that, you will have no scope to apply that. So understand that decision-making solutions will come, but the reality application will come only if you join the courses and upgrade your skills. But today's session will be a demonstration of how you can improve your psychomotor skills, okay? The reasoning skills. In that only you will know the difference. Then you can definitely concretely take a step into enrolling into the courses of the academy so that you get a long-term strong foundation towards betterment of the patient, betterment of yourself, and the betterment of profession. So ensure that whatever techniques I am mentioning, if it's a new technique, if I tell functional neuromuscular stability training, functional neuromuscular stability training, this is an approach where on day one, we start with the functional activity. Patient has difficulty with squatting, we start with the squatting on day one. Patient has problems with sit to stand. Patient has problem with walking. We start with the walking on the day one. Be it ortho, neuro, or cardiopulmonary, what is that functional problem of the patient that we start on day one, which is called as the functional neuromuscular stability training. This approach is not openly available everywhere. It's the combination of which I told you just now, the kinetic and the kinematic. The kinetic is influencing through the therabands, the muscle activity during the functional training. The painful functional activity is made into a pain-free functional activity by the use of therabands. Kinematic component of the functional neuromuscular stability training is giving the mobilization force to the joints, either through hands or through the mobilization belt. And what happens because of this is they are changing the joint loads and the joint mobility during the functional activity, what is called as functional mobilization of the joints. And this, both the options definitely are open. Everyone can explore the probability of training the patients functionally on day one. But most importantly, if you don't take the course, you will be doing a trial and error because you don't know which muscle to identify to support it with the TheraBand, which muscle to identify to inhibit it with the TheraBand, because you can use the TheraBand in different directions, either to activate the muscle or to inhibit the muscle. You can use the TheraBand for concentric activation and eccentric activation. So these are aspects which comes with instructions. Especially when the patient is in weight bearing like stair climbing, you know that closed kinematic activity is eccentric. So eccentric training has to be, and nowadays, even upper limb pathologies like lateral epicondylalgia, they have come to the situation where eccentric training of extensors on day one has accelerated the functional recovery. So understand the role of functional treatments. And see that when you do that, the patient's question about how many days I'll become normal usually will be minimized because they'll not ask that. Even if they ask, you will still know that today the patient's performance in the stair climbing is 25%. You expected the patient to perform better, but they performed 25% of that. And they had a recovery, they had an improvement. They were able to climb the stairs. After 5 steps, they are not able to again continue. You know that definitely the habituation phase, within 1 week, the patient should be able to climb stairs up to at least 20 steps. If the exercise prescription is given with divided regime, okay, throughout the day, do the exercises, not like 10 repetitions morning, 10 repetitions in the evening. Never. No exercise, be it musculoskeletal or neuro or cardiopulmonary, please do not advise the patients to do morning 20 minutes and evening 20 minutes. Make sure that the exercise has to be throughout the day. It has to be 2 minutes, 1 minute, 5 minutes, 3 minutes, randomly throughout the day. So that the 24 hours, the patient gets 1 hour to do exercises. At the same time, the exercise becomes part of the routine. And the exercise is no more for the joints or the muscles. It becomes the exercise for the brain because it is there throughout the day. And the patient can never tell that I don't have time to do the exercises because it's hardly 1 minute. You tell them that every 1 hour do 1 minute. In next, for example, in the next week, you tell them every half an hour you do 1 minute. The subsequent follow-ups, if you want to increase the repetition, you tell them every 15 minutes do 1 minute. Keep an alarm in the watch or in the phone. Keep the reminder. There are many apps that have come. And let it be distributed throughout the day. It's easier for the body to do it. If I have difficulty to lift my shoulder, will I do it 30 times or 50 times? Impossible. So I will only do 5 times comfortably, correct movement, a proper quality of movement. After 5 times, all the substitutions will come. Why to do that treatment wrong? Ensure that less repetitions, good quality exercises, specific exercises. You are focusing on the problem and you are targeting the exercises. It's not like all the knee pain, you give the quadriceps exercises. You have to see that the knee pain is from pes answering bursitis. You have to see the knee pain is from iliotibial band. You have to see whether the knee pain is from rectus femoris, or is it from the hamstrings, or is it the gastrocnemius or the popliteus. All these muscles can be exercised separately, even in a weight-bearing closed kinematic chain. Functionally, you can train for popliteus, you can train the rectus femoris, you can train the pes answering. In the pes answering tendon, there is sartorius, semimembranosus, and the sartorius, semitendinosus, and the gracilis. It's not the membranosus, it's the tendinosus, STG. Iliotibial band is just a continuation of the tensor fascia lata. So remember that exercises for the tensor fascia lata, hip component has to be more. Whereas exercise for the iliotibial band, the knee component has to be more, the tibia component. Hamstrings, they cross the hip joint, they cross the knee joint. We have to evaluate the hamstring dysfunction, whether it is at the hip or at the knee. You can't say hamstring tightness is present. Tightness is a static phenomena. As a physical therapist, we should not focus on that. We should see whether it is underactive or overactive. Hamstrings activation, is it less or is it more? That is what we want to know. Because it's a muscle activity. You have to modulate that muscle activity. If you are concerned about a passive property of the muscle, more than the tightness or the shortening, you should be more bothered about the muscle's adhesion with the fascia. When the muscle is adhered to the fascia, the flexibility of the muscle will be reduced. So you release the fascia, muscle becomes flexible. So remember that you don't require to stretch the muscle to make it flexible. You just have to release the muscle so that the muscle becomes flexible. The concepts have changed. Even for athletes, they don't advise stretching. So please update yourself with the globally applicable knowledge, which is developed depending upon the thorough fundamental principles of pathomechanics and patient-centered decision making. So this is how we are trying to what is called as address the extreme ends of the spectrum, because a patient might have constant pain, sleep disturbances. Another patient might have pain after working out for 3 hours. Then only the pain comes. This patient has 24 hours pain, constant pain with sleep disturbances, like a rotator cuff tear in a shoulder. This patient gets, after playing the sport for 3 hours or 4 hours, then they get the shoulder pain. It is similar to kind of a slap lesion, superior labral tear, anterior to posterior, with the long head of biceps, tendinitis. Many pictures might overlap. As a physical therapist, your focus has to be not on the disease, because disease is a terminology coined by the physician. Physician treats the disease. You are not treating the spondylosis. You are not treating the stenosis. You are not treating the radiculopathy. You are treating the patient who has a difficulty in moving the arm above the shoulder level, or you are treating the patient who is having a difficulty with the gripping. You are treating a patient who is having a difficulty with writing or signatures. You are treating a patient who has a difficulty with neck rotations. It's not cervical radiculopathy. It is not thoracic outlet syndrome. It's not the myofascial pain which you are treating. You are treating a patient who is having a functional problem. When you focus on this patient with the functional problem, and then you start the session with the functional treatment, the diagnosis does not matter. Even if it is post-operative, even if it is kind of muscular, articular, ligamentous, bony, anything and everything. Infection, malignancy, after that the patient is sent for physiotherapy, whatever. Ultimately, what I want to know is a patient with the neck symptoms, whether he is having giddiness. The giddiness and the vertigo is important for me in the cervical. The same way, headache. The headache from the cervical spine, whether the patient is having. Because these will identify the patients who are having severe functional deficits. You have a headache, you cannot do your activities. You have giddiness and vertigo, you cannot do your activities. They are worse than the patients who are just having movement problems. Neck movements are creating pain. They are minor compared to people who have headaches and giddiness. So like this, which will affect the functional activity more? That has to be treated first. If you ask me between the giddiness and headache, I will say giddiness is important, because that affects the balance. The person himself cannot stand. They'll collapse. If they have a vertebrobasilar insufficiency, it is like a transient ischemic attack for stroke. So patient can collapse anytime. So that is higher priority for me, the giddiness and the vertigo. I will not think of it as a simple vertigo unless I screen the other types of vertigo. And the same way, next priority is obviously headache, because headache affects your cognition. A patient cannot tell a history if they have severe headache. They cannot even look at you. Understood? So understand that suffering, when you have a headache, you know how much it is. Don't just think that why patient is not cooperating. It is your empathy, your behavior that will bring the cooperation. Sometimes you will have to start treating immediately. And subsequent sessions, the history will come. So don't think that first day you have to take a history according to David Maggie, and 1.5 hours is gone in the history itself. So that is why you need to undergo courses which teach you the reality. So that will make you competent enough to immediately take quick decisions, make you dynamic to modify the decisions throughout the way, and ensure that the functional recovery is not compromised. And you as a healthcare provider, your ethical responsibility to ensure the patient has to get better is also not underperformed. So ensure in which way you can focus and see that how this discussion today can empower you to make you better quality decisions in clinical practice. One of the common clash in the mind that comes is between the X-ray, the lab investigations, and the clinical findings. Even history. History is his story, his or her story. Examination is what you are performing, how the patient is performing, the challenges which you are giving. That is examination. There may be conflict between history and examination itself. There may be conflict between examination and the lab tests, blood tests. There may be conflict between the clinical examination and the X-ray. So what will you give maximum importance? You are not a counselor. You know who is a counselor? Counseling, the professionals will give importance to history. Because for them, the verbal interaction one-to-one is the only way by which they make decisions. A counselor, a social worker, for them, history is important. For us, it's not. Lab investigations. Are we a biochemistry specialist? Are we a pathologist? Are we a immunologist? To identify the parameter, we have to take the blood parameter. Our exercises are changing the blood parameters. So you want to focus on the blood tests. Impossible, because you know that your competency is only to identify a major abnormality in the blood test, but you cannot tell what exactly is the problem in the patient by seeing a blood test findings. The medical lab technology, there are various professions who are well competent enough to know the findings, not a physical therapist. Same way a radiologist, accessing the X-ray or an MRI is totally different. They diagnose the MRI, they diagnose the CT scan, and they report only the film. And they know the limitations, and they tell in the report that please correlate clinically. Don't go just by the scan. They are expert in the scan, but still they are telling with that sentence that please correlate with the clinical findings. That always will come in the report of an MRI or CT scan. Because you can't treat the MRI. Ultimately, whom you have to treat is patient. So now physical therapist can focus on what? History is ruled out because we are not a counselor. Radiological testing is ruled out because we are not a radiologist. Blood tests are ruled out because we are not a hematologist, we are not a pathologist, we are not a immunologist, we are not a biochemist. Only thing what we are is a clinician. So clinical examination is only our focus. If you do not focus on the clinical examination, you are not a clinician at all. If you are focusing on treatment, you are a treatment technician. Because treatment techniques are there, you are focusing on which technique I can give. Afterwards, which techniques I can combine. Treatment. Everywhere my focus is how I can treat a cervical radiculopathy. How I can treat a lumbar stenosis. How I can treat a coccydynia. That means it's technician question. What you should think is, what all I should evaluate in a coccydynia? What all I should examine in a sacroiliac joint problem? What all I should examine when the patient is having a heel pain? What all I should examine when the patient is having a carpal tunnel syndrome? That is clinician physical therapist. Unless our perspective shifts into this focus, whatever you learn with the techniques, you will stay as an advanced technician rather than being a clinician. So understand what makes you as a clinician is the clinical decision making as a continuum of a focused physical examination. We are not doing a full examination. To cite an example, I tell, if Miss Lucy, she has severe pain in the neck, she had her exams, she was studying, she was writing for long hours in the exam, and she has severe neck pain, she's not able to sleep. I will examine Miss Lucy with which movements are relieving her pain. I will not treat her without examination. I will examine, but what will I examine? What all relieves Miss Lucy's pain, the neck pain. So the direction of examination is relief of symptoms. Whereas Dr. Chaitanya tells, I drive the car. After driving the car for 2-3 hours, I get neck pain. Dr. Chaitanya mentions like that. She's not having 24 hours pain. She's not having sleep disturbances. So what will I do? I will keep her upper limbs forward like in the driving position. After which I will check the neck movements or neck contractions because the upper limb has to be in a position of the driving. If I keep Dr. Chaitanya in the normal sitting and then examine the cervical spine, it's injustice because her symptoms are present when the upper limbs are here in this position, not when the upper limbs are relaxed. So that is where the functional perspective comes. I may not exactly be able to reproduce what Dr. Chaitanya has as a difficulty, but I can always tell her to keep the hands like this, supported, because the hands are always on the steering of the car, driving. So keep it like this, and then examine the neck, upper cervical lateral flexions, upper cervical rotations, everything in this position only. That is where I am concentrating on functional aspects. Whereas for Miss Lucy, her problem is, oh, please, Professor Senthil, please. Okay, I have severe pain. Okay, she will talk like this. Please help me out. Exams are over, but I'm not able to enjoy my holidays. She'll be very sad. So there the focus has to be relieve the pain because it's not a functional problem. It is 24 hours problem. Whereas Dr. Chaitanya is after an activity, it comes. So that activity position only you have to examine. That activity has to be treated. First day when I make her to sit in the driving position and then I examine the cervical spine and I treat her in the driving position, Will Dr. Chaitanya ask me, how many days will it take for me to become normal? She will never ask, because that is the picture there. Because I have difficulty in driving, and the therapist was finding out what are the abnormality with my driving. So although it is a myofascial pain, what Dr. Chaitanya might have, or even Ritu ma'am, she's treating the patients. She's treating a neuro patient 24 hours. So she gets neck pain, Ritu Sani ma'am. It is also myofascial trigger points only. Both these are totally different. Both may be having trigger points in the upper trapezius. Diagnosis wise, both of them upper trapezius trigger points, even Miss Lucy also. But her problem, Lucy's problem is with spasm. Chaitanya's problem may be underactivation or overactivation, but not spasm. Ritu ma'am's, if she is working heavily, then she gets a severe pain where she has to apply external applications and take medications. Otherwise, she cannot sleep. So that means spasm comes in between after a overuse. But some days when she is tired, Ritu ma'am, morning itself, she will get the neck symptoms when she is handling the patients. It's not a must that evenings only will get the symptoms. Overuse means. Overuse symptoms can come in morning if the previous day the person was tired. That tiredness could be she was helping in a family function. So every person will have a background. Yes, we are concentrating on examination. Next priority is, of course, history. From the history, which all will match. Okay, so that we can keep fitting in. Next only we will think about investigations, which is the radiological or the hematological, the lab investigations. So see the order of priority. And whether you can do a movement test, whether you can do a muscle test, but definitely everyone you can do palpation. So please upgrade your skills of palpation. In neuro also, you can evaluate the tone of the muscles by palpation itself. You can palpate the muscle belly when you are tapping at the tendon and find that it is spastic or hypertonic. Hypotonic, palpate the muscle belly and tap at the tendon. You can still feel that the muscle is not at all reacting. Hypotonia. Palpation is a very, very important skill which will not worsen the symptoms if you are respecting the tissue behavior. Without seeing for the tissue behavior, I have a pain here, and you bring your hand and then you see like, where is the pain? Where is the pain? Where is the pain? Where is the pain? And then you are giving a pressure, it will aggravate. But if you are keeping such that, see for the temperature, see for the mobility, the soft tissue mobility in different directions, palpate and see, do only touch, and then asking the patient to do the joint movements, see that, after which then you come to the fact that, okay, go deeper, and then the patient tells it's paining. Immediately you ask, how much is the pain? It's 2 out of 10. Stay less than the 5 out of 10. Wherever you are, don't provoke the pain beyond 5. You bring it to 4 or 5, patient will be happy. Yes, my therapist found my pain. This is the pain which I had, doctor. Okay? But it is less. That itself will tell you a clue that, yes, what is the tissue? Whether it is the joint, whether it is the ligament, whether it is the muscle, which fiber of the muscle. Everything we need to bring back our background knowledge. Okay? What we have either from anatomy to biomechanics to the what is called as the pathomechanics, the abnormal behavior in the presence of a dysfunction. So ensure that the clinical spectrum, you should be very, very flexible and dynamic. You can't be like, last week I did that for that patient, it has improved. After that, I treated 10 patients, I gave the same and everyone improved. So I am going to use that technique only first. It means that you are a technician. You are not a clinician. So understand each and every patient is different and evaluate each and every patient depending upon what is the problem that they have. Not the diagnosis is a problem. It is the functional limitation that is the problem. And the functional limitation will never be same between two patients. For example, if you look at Lucy's neck is a shorter neck. Ritumam's neck is a little longer neck. Chaitanya neck is not visible. Okay. Oh yeah, she is also having a longer neck. Okay. So Dr. Chaitanya is also having a longer neck. Lucy is having a shorter neck. And this, again, Chaitanya, the upper limb length is important. The span of the upper limb is important because it was driving. Okay. For Ritumam also upper limb is important. The span is important. How long the upper limb length goes. Okay. Compared to the height. Because when she is helping a patient with transfers and functional mobilizations, the load on the back is determined by the length of the upper limb. Whereas for Miss Lucy, upper limb length is not that much important because it's only writing. It's a supported activity on the desk. It's not a reaching out activity. It is not a sports like a volleyball or a basketball where upper limb length will influence the cervical spine. So C for that anthropometry is different. Same way, the level of physical activity. Don't go by the body weight. Okay, body weight is just a what is called as it's an illusion. You get 100 kg person, whole weight is 100 kgs. Doesn't matter at all. As long as they can run, jump, and do all the physical activities, they are perfectly normal. You cannot tell them that they are overweight. Don't go by the body mass index. It is only for the endocrinologist, not for the physical therapist. If a patient tells that I feel like I have more fat here and I want to reduce, then keep that in the goals that yes, abdominal fat. So that should be the target. What we measure by skin fold caliper, we can measure the skin fold thickness. So that will be more important because the fat deposition, subcutaneous fat, regionally. The same way, exercise performance, how the parameters, the oxygen consumption, and also the metabolic parameters, how it changes after an exercise testing, will give us information on whether this patient is likely to develop renal problem, cardiac problem, or is it a pulmonary problems. So understand that exercise testing and prescription is there for everybody. Athlete also, diabetes, hypertension, obesity, everybody. But the parameters will never be same for two patients. A gross exercise prescription like 25 minutes of walking, 3 days a week, you can always tell. Anybody can tell, a neighbor can tell, a shopkeeper can tell. For that, you don't have to be a physical therapist. So ensure that what is the functional problem of the patient. Patient is getting breathless upon bending down. Patient is getting breathless when during toileting and then getting up. So that specific issues will be there. If the patient tells 3 issues, ask them which is high priority, which is moderate priority, which is least priority. If they tell all 3 are equal, you decide biomechanically whether you want to train sit to stand first or squatting first. Automatically, it's common sense to tell that without training sit to stand, you can't train the squatting. So treating the sit to stand will be the first priority, not the squatting. So these are some kind of an existential truth. It's not a what is called as a advanced ancient scripture which we cannot decode. This is common sense. And we should never ignore this. Patient has difficulty with level ground walking and stair climbing. Which one you will treat first? Of course, level ground walking. Because if level ground walking is not treated, how can you treat the stair climbing? So these are important. Some people have problem with turning around in the bed. And they also have problem with sitting, prolonged sitting having pain. Sacroiliac joint, for example. Turning around in the bed, they have pain. And prolonged sitting also, they have pain. So which one you have to treat first? Turning around in the bed is important because the lesser functional position, developmentally, the more earlier position has to be treated first. But it does not mean that I treat the turning around in the bed and I ignore the sitting. No, sitting also will be there in the day 1. But the emphasis for turning around in the bed, if it is for 20 minutes, I treat the patient for turning around in the bed. 10 minutes only I will treat for sitting. So that the patient gets a break. Okay. Sitting is also trained. Turning around in the bed is also trained. Unless, like Lucy, if the patient complies of 24-hour symptoms, then only I will be thinking of relief of the pain as my goal. Otherwise, improving the functional activity is the only goal. If there is constant pain, you relieve the pain, then automatically functional activity will improve. Intermittent pain, don't focus on the pain. You focus on the functional activity because brain understands only functional activity. So you train the functional activity, brain will know how to become normal. If you are focusing on the pain, you are creating a disability. Avoiding this movement, carefully doing that so that pain do not come. All this will enhance the disability of the patient. So with that overview, I would like to move on to the questions. Of course, various participants, some of them, the slots were given in the beginning of the session and they were not at the beginning. So what will we do now is we will ask Ritu ma'am first so that she can go ahead with her commitments. And then we move on with the other members. As I am starting the recording.